Right, I think I'll make a start. I think people are going to kind of enter for the next few minutes. So welcome everybody to today's webinar. So obviously, the title suggests it's on primary care themes predominantly, but we're talking about BRCA. And we're going to start off, Anna, he's going to talk about BRCA from a genetic counsellor point of view, and from a clinical genetics point of view. And she's a genetic counsellor. And then Izzy's going to take over and she's going to talk about it from a GP perspective. So that's going to kind of include like maybe identifying BRCA, but also how it could be managed. And I'll kind of talk about a few bits of signposting and educational opportunities at the end. Just a bit of housekeeping. Please do put questions in the chat, and we'll answer them at the end. I will share the slides at the end as well, and any links and stuff that we kind of talk about, I'll make sure that they get sent to you via email. And finally, if you don't mind just making sure that you're on mute so that obviously there's no background noise, unless obviously you're asking a question. And let me just share my screen. And Anna, over to you.
Thanks, Vicky. Hi to everybody. And thanks ever so much for giving us the opportunity to come and speak to you today about the whole genetics sort of journey, I guess. So hopefully I'll be able to give a brief overview about the current genes that we are looking at, which patients are likely to have an increased risk based on their genetics, and how we manage the patients that we think may have an increased risk. Next slide. Thanks, Vicky. So the current situation is that we've very swiftly moved on from testing one or two genes and moved on to testing panels of genes. So the update with the Cancer Test Directory, which is a national test directory, which is updated fairly frequently. Currently, there are 7 genes on this panel, which is a mix of the very high-risk genes. So we've got the BRCA genes and PALB2, which stands for partner and localizer of BRCA2, classed as a high-risk, very high-risk genes. And then we've got a smattering of 4 genes that are classed currently as moderate risk genes, but some of them, depending on the family history or the location of the mutation, can bump up to high risk, and on the rare occasion, very high risk as well. So we've got the BRCAs, PALB2, RAD51, and C and D, ATM, and CHEK2. The associated cancers predominantly, obviously the main one being female breast cancers, but there are some other risks of cancers that we've just highlighted in that end column there. Predominantly for the females, there is an increased risk of ovarian cancer, and of course pancreatic cancer also features in some family histories, although it's not, the risks aren't massive for this, but we always get a little bit suspicious when we see breast and pancreatic cancer in any given family history. Next slide. Thanks, Vicky. Of course, that list isn't exclusive. There are other genes that involve breast cancer risks, and we also need this is why genetics need a referral with upfront information on family histories, because we've got the TP53, which is Li-Fraumeni, and these come up with quite scary family histories of very young onset cancers, a broad range of cancers. We tend to see HER2 positive breast cancers sometimes in their 20s with these family histories, and sometimes we see childhood cancers like adrenocortical tumours in children, and sarcomas are the other things that we look out for. CDH1 is reported to give an increased risk of breast cancer, and these are lobular breast cancers in particular, but it's also on the background of family history of diffuse gastric cancers, sometimes very young onset, so 30s and 40s is a bit of a giveaway for these family histories. Then STK11, which is Peutz-Jeghers, there's a small increased risk of breast cancer and other cancers. Sometimes you'll see vague reports of intussusception because of bowel polyps, and some odd cervical and gynae cancers with these. But the last two conditions, P10, which is Cowden's, generally these individuals get seen by our consultant colleagues because they will need a physical examination because there's some key clinical features for these. Freckling, mucus on lips and mucal membranes for SDK11, P10 again various skin lesions and macrocephaly as well. So measuring head size is important for some of these individuals. Next slide. Thanks, Vicky. All of these conditions, all of the breast cancer genes that we currently know about, including the ones not on the panel, are dominantly inherited. So this means that you will just need one copy of these genes to be potentially at risk of developing a particular cancer. So offspring of anybody with a mutation in one of these genes, as you can see there, just the next, I think there's one last animation, Vicky, yeah, are at a 50-50 risk of inheriting the altered copy. So anybody who reports a germline mutation in any of those genes, we would like to see, but their risk of inheriting is 50-50. Next slide, thank you. Clearly, on the background of all of this, we have to sort of take into context how common inherited forms of cancers are compared to the population risk. And we know 1 in 2 in the general population will develop some form of cancer. At the moment, until we get to the point where we're testing everybody, we think inherited forms of cancer are run to about 5 to 10% of all cancer diagnoses. And of course, there are very specific clues when we're looking at family histories to establish whether there may be an inherited cancer condition in a family. Doesn't always run true, but this is what we look for. So on the next slide, thanks, Vicky. Yeah, just if you just want to scroll through all of these and I will go through them. If that's it, go back. So obviously, if any reports of breast cancer, especially if there's 2 or more generations affected by breast cancer, because as I say, it's a dominantly inherited condition. So we generally see multiple generations affected. However, this can be skewed if there's lots of male members in a family. So still refer in if there's any presentation of bilateral breast cancer in an individual, or if they've got multifocal disease, different morphology in the same breast. So we have to ask why. The related tumours, as I've mentioned, generally are ovarian, fallopian tube, prostate cancer and male breast cancer. But we did a study where we test all male breast cancers coming through the door because it is as rare as hen's teeth in some cases. And when we did an audit of it, I think there was about 10% hit rate for mutations in BRCA2 predominantly for male breast cancer and PALB2 as well. If you have an individual with a triple negative breast tumour, so these are estrogen, progesterone and HER2 negative tumours, especially in younger onset individuals below the age of 60, then we will test those individuals up front. Ethnically, we've got Ashkenazi Jewish, and there are other Jewish communities that are at a higher risk of inheriting a mutation in either BRCA1 and BRCA2. We've also got Icelandic founder mutations, and now more recently Shetland and Orkney Island, known as the Viking mutations. There's 1 in BRCA1 and 1 in BRCA2. So about 90% of mutations identified in this particular cohort are one of these founder mutations there. So ethnicity is becoming more important. Just so you know, there is currently a project that anybody who has a Jewish ancestry can access and enter. And it's run by our colleagues in London. I can't remember where at the top of my head now, but they will be eligible if they've got Jewish ancestry. They will be eligible for testing of BRCA1, BRCA2 genes in particular. So they don't necessarily have to come to genetics for a risk assessment. They can refer themselves to this project and have testing under the Jewish Research Project. Next slide, thank you. So as we can see here, we do get a lot of referrals into clinical genetics, some more appropriate than others, but because we're having moderate risk genes, this family history is possibly more suggestive of a moderate risk family, mainly because of the ages at diagnosis. But we would still be more than happy to see anybody with at least two generation and clearly, a lot of breast cancers being reported. We do try and confirm all cancers that have been reported in the family if we can, because as I say now, the devil is in the detail. And so knowing the hormonal status of this and age at diagnosis is more and more important for us because we do input all of that data into our risk assessment tools. So next slide, thanks, Vicky. This is more, as you can see here, we've got male breast cancer and an addition of an ovarian cancer. Because ovarian cancer is a lot less common than breast cancer, and we've got somebody there with multiple reports of breast cancer, this is more of a significant family history that would more likely suggest a very high risk family and possibly a mutation in one of the BRCA or PALB2 genes. So so just look out for the mix of cancers. The discrepancy here is that if we were to do genetic testing, ideally we like to target the most likely individual who is likely to harbour an alteration. So this would be the ovarian cancer patients. And so, since 2014, we've been asking our oncology colleagues to test all epithelial ovarian cancer patients. And I think that's been really quite successful. So it is possible that you guys will get reports from family members saying somebody in the family's had genetic testing and there's potentially a mutation in that individual. Next slide, thanks, Vicky. So referring in, it is important for us to get as much information at the point of referral as possible. So we have got these family history forms, which are on our website and can be downloaded. We do update them on occasion, so going to the website to get the most up-to-date version, we would recommend this. Don't stockpile them because we do get various iterations of old family history forms that don't always hold as much information as we would like. So if you are referring, please do use these up-to-date family history forms. As mentioned, if there is a report of a mutation in the family, it would be incredibly helpful if you could name names, not just an aunt or an uncle. If these individuals are known to us, we can access that information and we can expedite this referral a lot quicker. So if this individual knows the name of the relative and potentially a date of birth or an area where they live, it just gives us the heads up, and it's just so much more helpful if we can just try and get that level of detail, because us then organising and seeing them in clinic can be sorted a lot quicker. Also really important, if these are urgent referrals, that you just make us aware that this is an urgent referral so we can process in an appropriate way. Next slide. NICE guidelines. We base our assessment on the criteria laid out by NICE. All of our genetics colleagues do the same. So we tend to use 4 classifications of population: moderate, high risk, and very high risk. So the very high risk are like the BRCA1, BRCA2, PALB2 risk elements. High risk could be the ATM in CHEK2 if there is a strong family history, and the moderate risk genes may be RAD genes. But if there is a family history that puts individuals within this risk category, we measure both lifetime and 10-year risk. And just to get a level of consistency, we measure 10-year risk for everybody, regardless of their current age, between the ages of 40 and 50. And that allows us then to allocate specific risks. And alongside each of these risk categories are screening recommendations. Next slide, thanks, Vicky. So at the moment, we all use a risk model which can be downloaded. It is accessible. It is regularly updated. It's been developed by our colleagues at Cambridge, so it's reasonably dynamic. It assesses breast cancer risk It used to be called Boadicea, but is now called CanRisk. It also allows us to have a look at the mutation probability or hit rate in all of those genes, all of the genes on the panel plus two more, and it spits out a risk for us. So anybody who we've inputted all the data, spits out a risk of mutation hit of 10% or higher, we can offer genetic testing too. And genetic testing will be the whole panel. Clearly, as mentioned, there are other genes that are not really calculated. We can't calculate risk on them. So this is still very much clinical criteria and clinical acumen when we're assessing family histories to see what cancers have been reported. Next slide. There are two national screening criteria. There's NICE and the breast screening programme screening recommendations. They kind of align with each other, and this is what we base our screening recommendations on. Now we have a national data set where anybody who tests positive for a pathogenic mutation is entered onto a national register, and we generate screening forms for very high risk screening off that database. Genetics and oncology are the only ones that can request very high risk screening. So it's really important that these individuals are pushed through us in the first instance. It says here breast MRI from 30 to 50. For BRCA1, BRCA2 and PALB2, that starts from 25. As TP53, we tend to have a bespoke screening, and they will have MRIs from early 20s, possibly 2021. And it will be MRI scans only. We don't tend to use mammograms because of the risk of radiation to the breast tissue for TP53 carriers. And screening for P10, SDK11, SDKH1 does start from 30. And those will all be MRIs, and we add in mammograms for all but TP53 from the age of 40, and they will continue on that. They do assess breast density in the breast screening program. So if individuals do have a dense breast pattern, they are likely to continue with MRI scans past the age of 50, which is also very reassuring. For the very high risk group as well, they do have options for risk reducing surgery, and a lot of women do actually choose that. So if they have risk reducing surgery, they do not require any very high risk screening. And then there's the moderate risk group, which currently give us a little bit of a clinical headache depending on their age at which we're sending out these screening recommendations. So they get extra screening between the ages of 40 and 50. After the age of 50, they join the National Breast Screening Programme. But as mentioned, there's some potential clinical issues here between us and primary care with how these individuals are managed. Next slide, please. So yeah, at the minute we don't have, so anybody who falls outside of the ages of 40 and 50, i.e. those younger than 39, there is no robust recall system for these. We're very reliant on the patient either asking you when they reach 39 to refer them, or if all else fails, if their assessment was several years prior to them reaching the age of 39/40, we do recommend that you refer them back to us just in case that initial assessment has changed or screening recommendations have changed. We do have a lot of individuals fall through the holes in this and don't necessarily get this moderate risk screening, either due to poor communication or misunderstanding. So it's still going to be a bone of contention. So we are reasonably reliant on you either referring them to the screening units when they hit 39/40 or referring back to us. Sorry about that. Next slide. Yeah, the other sticky issue is how to manage the chemo prevention side. NICE have recommended the use of tamoxifen or anastrozole for individuals either at moderate or high risk of breast cancer. The current data suggests that there's an approximate 40% risk reduction if taken for 5 years or more. Don't generally recommend use before the age of 35, so it can start from 35 years or over. To be fair, it's not always tolerated because it does give menopausal symptoms, and there are contraindications. So if they're planning on having more children, it's not wise for them to take it. If there's a family history of blood clots, if they're breastfeeding, HRT clearly is contraindicated for something like this, or they've previously had an endometrial cancer. At the moment, we're not too clear the best way to manage this because we don't prescribe within the cancer genetics service. The breast surgeons, I think there are some breast surgeons that will have clinics and are happy to see, but the majority of them are not happy to see because they're too busy. And so then, the only option is it possible for primary care to prescribe this? So again, big question mark over that, and how you guys feel about doing some of this prescribing. Next slide. The other thing that we frequently get asked or ask from primary care is if we've got somebody in a family or a patient that's been referred in who is terminally ill. If death is imminent, it's really important for us just to try at least attempt to store some of their DNA before they die. So we are very heavily reliant on GPs and primary care teams like the district nurses and palliative care teams to help us out with that. We're always more than happy to send any information out to you. It's just a case of either getting a buccal swab or a blood sample from individuals. So at least we've got some DNA that could be referenced and tested at some point. Next slide. This is just to give you the heads up, actually. The UKCGG, which is UK Cancer Genetics Group, have clinical guidelines that are frequently updated. And this is what we base all of our recommendations on with regard to screening, risk reduction, hormone replacement, chemo prevention, and any management and impact on families. It also is fairly dynamic with regard to recording updates on lifetime risks for individuals. As you can see, this is a BRCA2 sheet. These are available on the UKCGG website, and they cover a whole range of different genes. Not every gene, but the main big genes that we are testing for. So this is a really helpful resource, and we very frequently will send these out to GPs if we're referring back and asking you guys to do specific things, just so you know where we're coming from. It is as evidence-based as we can get it. So it's just so you know that this is a really helpful resource that is readily available. Next slide. Risk management for ovarian cancer hasn't improved over, 40 years or so. There is no robust screening for ovarian cancer. So the standard advice for anyone with an increased risk of ovarian or fallopian tube cancers for BRCA1, BRCA2, PALB2, and the RAD genes. The RAD genes are synonymous with ovarian cancer risk. We do recommend that they consider having ovaries and fallopian tubes removed. It's important that fallopian tubes are removed as well, because the current evidence suggests that anything up to 70% of ovarian cancers will originate in the fallopian tubes. So it's important. It's up to the gynecologist and the patient to discuss whether they just have this as a day case, day removal, have a BSO, or whether they have a full abdominal hysterectomy. It depends whether there's any other underlying gynae pathology with these individuals. Next slide. Oh yes, and this is the newest sort of information that we have. We know, you may know that the UK Screening Committee have declined to offer population-based screening for prostate cancer because harms outweighing benefits at the moment. But the UKCGG group have asked for the high-risk groups. So this is the BRCA1, BRCA2, PALB2 groups to have national screening recommendations. So this was discussed in December 2025 and agreed upon, and they have suggested that a PSA test is done every 2 years between the ages of 45 and 61 for these males. At the moment, the screening recommendations haven't changed. So as you can see on the opposite slide there, that we're currently recommending PSA annually from 40. And this is, again, something we do request of you guys to help us manage with these patients. There are other high-risk groups, such as Afro-Caribbean groups and other ethnic groups that appear to be at higher risk of prostate cancer. The data needs to be a bit cleaner, and there are research projects that these individuals can be recruited into, so we can get some better data and as to whether we need to target these groups also for some additional screening. So yeah, so we're asking a lot of you guys, we know that, but we don't have the capacity to do that within genetics. And I know that you probably say, well, we don't really either, but we're very grateful for any help that you can give us in supporting. It's not going to be a massive group, but just this small group of males at least. Next slide. I think that might be it. So that's for me. Sorry, I probably ran over a bit.
Let me just stop sharing. And
I think there are a few questions.
oh, great. Sorry, I'm having a bit of problem with my IT now. Izzy, are you okay to share while we? Do you want to take some questions? While Izzy just sort of loads up her screen.
Yeah. So I think Kirsty said, what constitutes an urgent referral? So I guess anybody who is going through a diagnosis, or that isn't being managed by mainstream testing, we're always very happy to see and try and get to see them sooner rather than later. We're generally trying to get our mainstream colleagues to do testing, but that is limited to the current criteria in the test directory. There are some patients who kind of fall outside of that a little bit. So anybody that requires an urgent genetic testing, or those, as mentioned, who are very poorly or terminally ill that we need to organise DNA banking, please do flag that with us. The other things as well, Kirsty, is that if there is a known mutation in the family, we wouldn't necessarily class them as urgent, but we do like to see them sooner rather than later. So having that information up front in a clear way is really, really helpful, because it just allows us to expedite and organise a clinic appointment. Otherwise, they could be waiting months and months to see us. So if we've seen the patient and family, so if we know that we've seen the patient and family before, we don't always need a family history form. So if we've got that data to hand, then no, we don't always need that. So especially if there's a known mutation in the family and the family are known to the West Midlands service, then no, just refer them in, and we will update the pedigree drawing with those individuals when we see them. I can't see any more questions.
No, that's it, I think.
Yep.
Thank you very much. Thanks so much, Anna.
Thank you.
Great. Izzy?
Yeah, so can everyone see my PowerPoint slides? Just
Yeah,
give me a
that's
shout out
working.
if there's any problems. There we go. So my name's Izzy Fuller. I'm a GP working in the West Midlands at the moment. I also have a role with the GMSA, a sort of teaching and educational non-clinical role with them. So I want to talk to you a little bit about the role of the GP with BRCA. Now, of course, it's important that we recognise when someone has a family history of certain types of cancer. So this sometimes comes up in clinics just as a kind of off the cuff. Someone will say, oh, my mum was diagnosed with breast cancer, that's why I'm feeling depressed. And it can come up as part of a different consultation. And it's really important to kind of explore that a little bit with the patient to see whether they might be at risk. So what age was the mum? Do you have any other relatives with any other types of cancers, things like that? So it's not always that they've presented with this concern, but it might be something that we identify as part of seeing them for other things. And of course, we want to make appropriate referrals for genetic testing when we do think there might be an increased risk within a particular family. They might have questions about what's going to go on if they are referred to the genomics clinic, and Anna's gone through that really nicely with us about what they'd be testing for and how that test would go ahead. And as a GP, we're going to have a role that's specific to patients with BRCA. So this is going to be including ensuring that that patient's attending for screening, particularly in someone that's been maybe diagnosed in their late 30s. Have they had that appointment come through when they hit 40 and they can be referred on for screening? And of course, ongoing prescription of chemoprophylaxis, however that started, whether it started in primary care or secondary care, we're going to have a role in prescribing that. But our patients with BRCA are also people. They're going to have exactly the same kind of wants and needs as any other person that doesn't have BRCA. And sometimes some of the things that patients present to us with might be complicated by their BRCA diagnosis. So we're going to focus a little bit on family planning for the next few minutes. So if a patient comes to you and says, I want to have a pregnancy, but I'm concerned there's a family history of BRCA in the family, and I'd like to try and avoid passing that BRCA gene down to my children, we can refer them for pre-implantation genetic diagnosis. So what happens with this is they will go through IVF, the sperm and the egg will be fertilized and it will be allowed to mature to blastocyst, which is about the 8 to 10 cell stage. Then one of these cells will be removed from that embryo whilst it's still in vitro, and they will have a little look through a sequencer to see whether there is a BRCA variant there that's likely to cause cancer. And then they can choose which embryo they're going to implant. And obviously, if there is one that doesn't have that variant, they would implant that over one that does. But a patient may decide that they don't want to have any more children, so therefore we're starting to think about contraception. Now, of course, there are lots of non-hormonal methods of contraception that we can talk to them about, but a lady might have very heavy periods or problems and want to have that little bit of extra control and might want to be considering a hormonal contraception. So the place that I always go to look whenever I have any questions about whether a contraceptive method is suitable is the UK medical eligibility criteria. And they divide their advice into 4 categories. So category 1, we're saying no restriction at all for the use of the method. Category 2, we've got advantages outweigh the disadvantages. Category 4, kind of don't touch it with a barge pole. And then category 3 falls somewhere in between the two. As a general rule, I try and aim for prescribing ones that are either category 1 or category 2, and I tend to shy away from category 3 and category 4. So let's have a little look at where this lands us with BRCA. It says if there's a family history of breast cancer, now that doesn't specify who's got breast cancer, what degree of relation, how old they were. It is literally just blanket family history of breast cancer. And that's a UK MEC1 for all hormonal contraceptives, whether they've got the estrogen in or whether they're progesterone only. Once we start to know about genetic mutations, that risk then increases. So our combined hormonal contraception, which contains our estrogen, comes up to a UK MEC3. So that's something that I wouldn't go ahead and prescribe to a patient with BRCA. But our progesterone-only contraceptives are UK MEC2. So these would be the ones that I'd be erring on the side of using if a patient definitely wants to use hormonal contraception. Now, what does NICE have to say about it? The first thing, as with everything, we should be having an informed decision. So we should be informing our patients that yes, there is an increased risk of breast cancer with the oral contraceptive pill, but there are also benefits to taking the contraceptive pill. So it can decrease the risk of ovarian cancer. And when we are thinking about that, when we're prescribing the contraceptive pill, we're not just prescribing it for those risk reductions alone. It has to be that a patient wants it for contraception, and when they're deciding on their choice of method, they may want to choose a contraceptive pill that reduces the risk of ovarian cancer alongside it. Then, of course, any patient that goes through risk reduction surgery, if they have their uterus and their ovaries removed, they're going to be put into a surgical menopause, or they may just go into a natural menopause and they may be really struggling with symptoms from that. So they may come to us talking to us about whether they can start HRT. So can we actually prescribe HRT to these patients? This all depends on the age of the patient. So if they come to you under the age of 50, maybe they've had their surgery and they've gone into a surgical menopause, HRT does have a minimal additional cancer risk, but it also has massive benefits in terms of maintaining the bone density, cardiovascular disease health, and of course, symptom relief. And the British Gynecological Society and British Menopause Society have released joint guidance that recommends using estrogen-only HRT where appropriate after surgical menopause until the time that natural menopause would occur. So this is for ladies that have had their womb removed. Obviously, if they still have their womb, they need the progesterone to reduce the risk of endometrial cancer but caused by unopposed estrogen. Over the age of 50, the risk of breast cancer does start to increase, but only by 1 to 3%. So we need to have a really good discussion with our patients once we get over the age of 50 about whether they want to continue using it. So let's have a little look at those joint guidelines and see what they say. So again, they inform that it has to be an informed decision. Where appropriate, we need to be seeking specialist advice. So patients with a high risk of gynecological cancer should be referred to a specialist. So this would be our patients that go into a natural menopause that have maybe elected not to have their ovaries and uterus removed. Again, it says offer until the age of natural menopause, so that's around the age of 50, and continue it with caution over the age of 50. There is another condition called Lynch syndrome, which is an inherited cancer predisposition syndrome, which doesn't actually carry an additional breast cancer risk. So if any patients come to you mentioning Lynch syndrome, that's specifically mentioned in these guidelines as well. A nice talk about use of HRT with BRCA as well. Again, needs to be an informed decision. And they recommend using it at the shortest duration at the lowest dose and aiming again to stop over the age of 50. Where possible, we can be considering alternatives for specific symptoms, so whether that's SSRIs for hot flushes or mood swings, treatment of osteoporosis. There are lots of other alternatives that patients should be offered before thinking about HRT, and then allowing that patient to make their own decision as to what they want to take. And where clinically appropriate, we're supposed to be using estrogen only. So this again is, just to reiterate, it's when a lady's had her womb removed. If we give estrogen alone to a lady that still has a uterus, then she is at increased risk of endometrial cancer. So I'm going to give you a minute just to scan this QR code, and I will just find the link myself and post it into the chat, if you bear with me. We're going to just go through some case studies and some examples. So the link's in the chat. Is that now back on the screen with the QR code? Everyone see that?
Yeah, it is.
Yeah, great. Okay. So case one, we've got Maya. So Maya is 46 years old and she has a family history of breast cancer. She is tested positive for a pathological BRCA1 variant. She's never had cancer, but she's elected to have a bilateral mastectomy and nephrectomy, and she presents with hot flushes and brain fog, but she's very nervous about considering HRT. So what would you advise Maya about HRT? Should she not be prescribed HRT at all? Because she's under the age of 50, the benefits of bone protection outweigh the risk of breast cancer. She should use the lowest dose for the shortest duration and consider stopping after the age of 60 years. Or because she's had a mastectomy, there's no risk of breast cancer and she should not worry about using HRT. So if you will just answer that on the form, and then we'll have a look at everyone's answers at the end and see. It will all be anonymous, but we can see what percentage of you choose which option and go through what the correct answer might be. Case two, we've got Priya. So Priya is 55 years old and she was diagnosed with breast cancer last year. She had a wide local excision. Her biopsy results tested positive for a pathological BRCA2 variant. Before her diagnosis of breast cancer, she was taking Conti, and she felt it controlled her symptoms of fatigue, irritability, low libido, and brain fog. But she's now really struggling with her menopause symptoms again, and she really wants to restart her HRT. So what advice would you give? Would you restart the HRT in primary care? Would you give advice on alternatives? Would you refer to clinical genetics, oncology, or the menopause clinic for advice? Maybe more than one correct answer here, but it's always interesting to see sort of what we would all do and compare things. And then case three, Padma. So Padma is Priya's daughter and she's 25 years old. She doesn't want to have a genetic test. She wants to think about contraception. What would you advise her? Should she start contraception because it will reduce her risk of ovarian cancer? Should she avoid all hormonal contraception? Is the combined contraceptive pill the safer option, or is the progesterone-only pill the safer option? Right, I'll just give you a couple of minutes to finish those while I try and get the answers up on screen. Okay, so we've got some answers coming in now. Can everyone see the screen with the pie chart on it? Just shout out if you can see it.
Yes, thank you.
Yeah, perfect. Okay. So I'm sorry it's so small. It's on my laptop screen. It's having a moment. Might be just because a few more responses are coming through. So Maya is 46 years old with the family history of breast cancer with pathological BRCA1 variant, never actually had cancer but has had risk reduction surgery and has got menopause symptoms. So nobody said that she should not be prescribed HRT. That's fine. It has to obviously be a decision with her to make that. So yep, we can prescribe it. As she's under 50, the benefits of bone protection outweigh the risk of breast cancer. So we've got the majority of you there, about 60% answering with that. And yep, that is correct. The 40% saying using the lowest dose at the shortest duration and consider stopping after the age 60. Yep, absolutely, definitely using the shortest duration, lowest dose. The age we should be thinking about stopping is age 50, and that's when we should really be having that discussion with the patient about whether they want to continue using. And of course, there is still a slight risk of breast cancer because you can't guarantee that every single breast cell has been removed when they have their mastectomy. So obviously, she doesn't need her screening, but you don't want to be giving her additional. There's not no risk at all. So that would be misinformation for the patient. Now we've got Priya, who's 55, who's actually had breast cancer but has been on HRT before and is positive for BRCA2 and wants to restart her HRT. So no one's confident at restarting the HRT in primary care. I think I would agree with that. She's had breast cancer before, and breast cancer is a contraindication to HRT. So I certainly wouldn't be restarting it in primary care. Yeah, about 2/3 of you giving alternatives to HRT. Brilliant. I would be doing that. Clinical genetics aren't really going to be able to help us on this one, and no one's put for that because obviously they're non-prescribers. And then between oncology and the menopause clinic, because she's high risk, if she's absolutely desperate to restart her HRT, so obviously she's at high risk of, she's had breast cancer before, she's high risk because of the BRCA2 variant. She hasn't had the breast tissue fully removed, she just had the wide local excision, so she is incredibly high risk. But having said that, if she's living with menopause symptoms and she's really struggling, she may well decide that she wants to take that risk. And of course, she can have that discussion with her oncologist or with the menopause clinic and really make an informed decision on whether she does want to take that risk. The oncologist is definitely someone to keep in the loop here because a lot of it will depend on what type of breast tumour she had, whether it's estrogen receptor positive and things like that. So I certainly wouldn't be prescribing in primary care, but we can certainly ask for advice and guidance or refer her to specialty if she does desperately, absolutely want to restart the HRT and wants a discussion on that. So what about her daughter who doesn't want to be tested but wants to think about contraception? So, yeah, it's definitely going to be reducing her risk of ovarian cancer. That's not the main reason for prescribing it. So if she wants to start contraception, you can advise her it will help with her ovarian cancer, but she shouldn't just be taking it just purely for that indication. She needs the contraception. She needs to have the benefit of the contraception as well. Otherwise, it's used completely off license and against guidelines. Doesn't need to avoid all hormonal contraception. And progesterone-only pills. So when we look at the UK Met guidelines, if we didn't know about this BRCA variant in the family, we'd be looking at her being a UK Met 1 because there's just a family history of breast cancer. So technically, we're just a UK Met 1 from that family history point of view. But we know that there's a BRCA2 variant in a first-degree relative. So we know that Padma's risk, although she hasn't been tested, of having a BRCA2 variant is 50%. So this is where we kind of use our genetics knowledge and look at the guidelines and say, actually, the progesterone-only pill we will be looking at as the safer option because we know she's at a much higher risk than the general population of having a BRCA2 variant. So I would agree with you there that I would go for the progesterone-only pill in this case. Of my case studies, I'll see if there's any questions in the chat and then I'll hand you back over to Vicky to go through a few little housekeeping things at the end.
I couldn't see any questions. We were just talking about somebody was using CliniB or QGenome, and we were talking about kind of the merits of that. So
Yeah.
quite helpful for me. But I don't think, has anyone got any questions that are kind of more specific to sort of GP primary care? And feel free to just shout out if you do. Any general questions? Oh, Kirsty?
Was Thanks for the presentation. It's really helpful, and knowing that there's these other genes that are now tested and things as well. So if we've got patients who have been tested in the past for their family history and were sort of told that they weren't necessarily eligible for testing at that time, might that have changed with the sort of change in the panels of things that are tested now? And if they're still concerned and they come to us, should we refer them back to you now?
Yes, do that. We have tried to go back with some of these patients, but there's going to be some that have had previous testing, especially with the old testing techniques, where we may find mutations. But with the extended panels, yeah, there might be other genes that we need to consider. So if there is anybody, yeah, please do refer them back. We're more than happy to see them and test them again if we can.
And can I just check as well, can patients actually self-refer in without us also doing a referral? If they pick up the family history form sort of on your website?
Yeah, they can. The main sort of self-referrals that we are happy to accept are those with known mutations in the family. So, by word of mouth, if you've got a family member who has had a mutation, then we do actively encourage them to contact us directly, bypass you guys to save that element of work, and we can get them sorted sooner rather than later. Yes, they can complete the family history form, but if we get over 6,000, it creeps up over 6,000 referrals into the cancer genetics team alone, and we do struggle on occasion to process this in a timely manner. So we're kind of moving towards that. We would prefer there are criteria for referral into genetics. If they meet the criteria, yes. If they don't, please don't.
Is there, I mean, and again, because sometimes there's a lot of information out there for us as GPs. There's so many, and the guidelines change. And so it can be really difficult to sort of, know and access easily, should I be referring this family or not? It's a lot of work for the patients to collate the information. Often they kind of come to us with half-formed bits of family history. They're not sure about this, not sure about that. So it's actually really difficult sometimes to kind of, so I'd ask them to do the family history form first, but then is there an easy way for me then to review that and go, oh no, I don't need to refer you on? Or, and I apologize if I ought to know this already, it's just that
No.
there's so many referral criteria
Yeah.
for so many different things.
No, I get it. I get, you guys have information overload really, because the book stops with you for so many, well, everything. So we do update the referral guidelines very frequently on the website. So everything that you need to know is there. But as Vicky mentioned very briefly, CliniB is an app that we're the utility of which we can see would be really helpful, especially for GPs, because you can just work through it with the patient and it will give you an answer as to whether to refer on or not. So, there are some apps and things that we hope at some point to bring online. Fingers crossed that may be helpful with this. Vicky, would you agree?
Yeah, definitely. And yeah, Kirsty, we get this a lot, so from lots of GPs. So you're certainly not kind of alone in this. And I think it is often very complicated. But yeah, there are apps. They are used in some parts of the country and not others. And we are kind of putting a case together to try and get that purchased in our region. So hopefully that will be fairly soon. And I can obviously update anybody on this call when that happens. and sort of signpost towards that. I think Rahini, I don't know if you've got anything to add to that, because I know you've used it via friends or colleagues, but I think there's limited access if we currently, and then obviously full access once we make the purchase.
So yes, when my friends have used it, they find it very easy when they are consulting with patients to quickly determine if this patient needs a referral or not. And as I mentioned, when I use it, it only takes me up to a certain level, and then it stops. So I haven't really been able to use it fully. But when we have a WhatsApp group of menopause specialists, and they write in there, and most of them are from the South as well. So they have seen the benefit, is what I would say.
Yeah, so when I have an update on that, I'll certainly let people know. But I am sort of trying to get people to trial it as well, within kind of general practice. So if anyone wants to sort of put their email in the chat, I can see if I can get you a trial basis of that. And the more kind of opinions we get, positive or negative about it, obviously the better it is for our case. So feel free to kind of reach out to me or put your email in the chat, and I can get in touch with you directly. Thank you very much, Renee. And other than that, I'm just gonna very, very quickly, I promise. I've popped a let me just share my screen again. So if you could please complete a short evaluation, and I'm also just gonna very quickly just do a tiny bit of signposting of things of a genomic nature that you may be interested in. Just bear with, it's taken a little while. So I'm Vicky Geddes, so I'm the Education and Training Lead for Central and South GMSA, and I'm sorry I've got a terrible cold, so my brain's working at about 5% of its usual capacity, but I can just about still use Teams. So there's my email address if anyone wants to get in touch with me, and thank you for your emails. So we just do lots of different things, such as webinars that you've seen today, and this one's obviously a bit more specific, and it's got kind of a primary care focus, and I think a lot of you on the call today are GPs, but we do a lot of things as well, with nurses, with midwives, with pharmacists. We've done kind of full days for GPs and so on. So there's a link there which I will include on an email, so don't worry about clicking it now, and it's sort of more of a sort of expression of interest so that I can keep in touch with you if things come up, as and when they do. I just included this here in case anyone is especially interested. So this is the prostate cancer conference that's coming up towards the end of March, and particularly that may be of interest on the first day, and it's all online, and I believe it's recorded as well if you can't make it. Is a kind of a session that's very specific to prostate cancer from a genomics point of view. So they're talking about BRCA1 and BRCA2 on the first day of that. So I will send that link as well. In April, the 28th of April, there's a bowel cancer webinar, which will include some primary care themes, and some sort of general themes from clinical genetics. And we've also got another webinar coming up in early May about pharmacogenomics, and all of these will be available on our website. There's a whole kind of bank of past material that you can find if you search Central and South GMSA on YouTube, and we did one around this time last year, which was again different primary care themes, and you can see that in the first section here. So it's very tailored to sort of things that kind of present in primary care, so including cancer, but also including things like FH, hereditary hemochromatosis, and so on. And for the for those GPs amongst you that have loads and loads of extra spare time on your hands, if you're particularly interested in genomics, then I just want to kind of make you aware, if you're not already, of a genomic medicine MSc that is available, and obviously I'm sort of talking to you today from Birmingham, so there is a face-to-face version of this course in Birmingham. It's funded by the NHS, and you can do like a whole master's if you choose to, or there's modules available which take roughly about 5 days, and then obviously a little bit extra for kind of essays, exams and stuff, which you may just do a CPD. And I've just kind of screenshot here a few examples of ones that you could choose. But I think there's about 15 different modules available. And other than that, I've promised I'll get in touch with you about kind of Clini B / Q genome as and when I've got some more information. These are just bits and pieces for any midwives or nurses on the call today that might be of interest. And again, all of this will be shared, but these are sort of it's like a tool. It's very similar to the accreditation process, that the revalidation process that nurses and midwives will be aware of, where you can kind of do a more self-guided look at genomics, and the tools to do that are there. And other than that, feel free to kind of get in touch with me, anything education training related, and that link there is for our website. And last but not least, please, if I could ask you again to do the evaluation, it would be much appreciated. And other than that, thank you very much for giving up your lunch breaks, and hopefully you find that useful. And I'll stay online in case anybody has any last questions for a few minutes. And thanks again, Anna and Izzy, of course. Thanks. Bye.
And thank you very much. May I ask you a question?
Yeah, of course.
My name's Becky. I work at the Royal Berks. I'm fairly new to my role as breast cancer nurse consultant, and I'm just wondering if there's any sort of courses out there that really are specifically around breast and screening programs, just to increase my knowledge. I've got a general overview of cancer, but I haven't worked specifically with breast cancer before. So I'm just wondering if there's any sort of education around that.
Yeah, so do you mean kind of specifically to breast, or kind of genomics?
I think I probably, overview of genomics, but I think I'm biased, of course, and focusing in on breast cancer.
Yeah, of course. I mean, I can't answer for the whole of the sort of breast cancer space, but we do so one of the things that we do on a fairly regular basis is a 3-day face-to-face course for nurses, and it's genomics, and breast does feature quite heavily in that. So
Okay.
the first day, I can share a link with you for, in fact, if the expression of interest that I shared before, you could put your name down on that. But on day one, we do like very fundamentals. On day 2, it's a bit more to do with kind of consenting for genetic testing and
Yes.
ethics and so on. And then we have like different case studies, which always includes breast. So that's something that I could definitely send your way
Thank you.
the next time it comes up. Other than that, I think do you use, are you familiar with Yukons?
Oh yeah.
I think they offer things. I'm trying to think of anything specific off the top of my head, but I can't think of anything specific to breast. But I can certainly sort of share with you kind of genomic breast things that we do.
Thank you. That's really helpful. Thank you.
No problem. Thanks.
I'm going to say cheerio, but thanks very much.
Yeah,
It was
sure.
really
Do have a look at the
informative.
passport as well. I think it's got a bit of signposting for resources that some of them are quite specific to breast cancer.
Thank you very much. I was taking notes as you go. I probably can't read my own writing when I look back at them.
Yeah, no, I'm very much the same. My brain only works when I've got a pen in my hand, though, so I think it still goes in somewhere.
You've done well with a cold. Thanks very much, everybody.
Yeah, thank you.